One second. Good evening, one and all. I take great pleasure and privilege in welcoming Dr. Naresh, Dr. Naresh Shanmugam, who is a consultant hepatologist in Rela Institute, and he has done his master's in nutrition. And it's good for this academic program to have an expert like Dr. Naresh in the forum. Welcome, Dr. Naresh, and thanks for joining.
Thank you, Dr. Uma. Thank you.
Today we know that parental nutrition are very important aspect especially in extremely preterm babies, because they happen to born very early, and their nutritional requirement would differ. So even though it may not be totally parental, it will be partial parental nutrition, which is used most often in neonatology. Though it was started in adults, I think mostly it is used in more than pediatric, it is being used in basically neonatology. I request all the participants to mute their mic. Sachin, Sachin is going to take us through on parental nutrition, especially concentrating on preterm neonates. Over to Dr. Sachin.
Thank you, ma'am. Thank you, sir. Today I'll be discussing about parenteral nutrition in preterm neonates. I'll be discussing the topic under these headings: introduction, the components of parenteral nutrition, mainly macronutrients, which includes carbohydrates, proteins, and lipids; micronutrients, which includes trace elements and vitamins; and monitoring of a child who is on parenteral nutrition, and complications of parenteral nutrition. Coming to introduction, so as we all know, the incidence of preterm birth is on the rise both in developed and developing countries. It accounts for around 11% of births worldwide, and this preterm population is prone for postnatal malnutrition, and the incidence of this postnatal malnutrition is higher in as the gestational age decreases. So why these preterm neonates are at high risk of postnatal malnutrition? The preterm birth itself interrupts the physiological growth path of the fetus, and as soon as these babies are born, they are in need of higher energy to maintain their thermal and metabolic homeostasis. So, for example, if you take extreme preterm, so it is physiologically handicapped by as it has little or no subcutaneous fat and low stores of glycogen and key nutrients. So because of this inadequate nutrition, they are prone for growth failure, which in turn causes susceptibility to infection, and it again causes a vicious cycle. So the main solution for all this is effective nutritional support of premature and critically ill infants with parenteral nutrition. So what is parenteral nutrition? So according to ESPEN, that is European Society for Clinical Nutrition and Metabolism, they have defined it as metabolic nutrition therapy, which is provided through intravenous administration of amino acids, glucose, lipids, electrolytes, vitamins, and trace elements. So we can categorize a parenteral nutrition into total parenteral nutrition and supplemental parenteral nutrition. So total parenteral nutrition mainly here there will be no enteral nutrition as such. So all the requirements of the baby will be met by parental route. In supplemental parenteral nutrition, here both enteral and parental route will be used for the nutrition. So a little bit about history of parenteral nutrition. So in 1968, Stanley Dedrick and Douglas Wilmore, these are the two surgeon researchers who were working in University of Pennsylvania. They both worked for the introduction of the parenteral nutrition. Initially, they worked in the usage of beagle puppies. Later, it was used in malnourished adults who had a surgical complication and GI conditions. The first safe parenteral nutrition was used in a female neonate who had total bowel atresia in Children's Hospital of Philadelphia, and this baby was fed for around 22 months with the parenteral nutrition. So what is the evidence for the usage of this parenteral nutrition? So there are studies saying that early use of parenteral nutrition causes leads to minimal loss of proteins, and it improves the growth outcome. And there are studies showing that increased protein and energy intake in first week of life leads to higher Bailey mental developmental index scores at 18 months of corrected age. So what are the indications of parenteral nutrition? Mainly, I'll be talking about preterm parenteral nutrition. So what are the other indications to start parenteral nutrition? So mainly, if the gestational age is less than 32 weeks or less than 1,500 grams, you'll be starting parenteral nutrition. So if the weight of the baby is more than 1,500 grams, whom we expect not to initiate or tolerate enteral feeding for more than 5 days, there we have to consider parenteral nutrition. And other conditions like severe intrauterine growth retardation, necrotizing enterocolitis, gastrointestinal problems like short bowel syndrome, and surgical conditions like tracheoesophageal fistula, intestinal obstruction, malnutrition with volvulus, omphalocele, and gastroschisis are some of the conditions where you consider parenteral nutrition. So coming to components of parenteral nutrition. So first is proteins. So as soon as the baby is born, if you're
Sachin, just can you stop here? I'll just put the first poll.
Yeah.
So to make it interactive, we thought like we can have poll questions. So I launched the poll. I request all the participants to answer the poll for this. So the first question is, do you use TPN for preterm neonates in your unit? The second question would be, how much of protein do you start on day one in case if you are using TPN? So I think more than 50% have participated. So out of 57 participants total, I'm seeing 34. So I'm reading the poll. I'm sharing the results now. So basically, I think the majority of you are using total parental or partial parental in the respective. I think it is glad to know. And how much of protein do you start? I think again majority are starting 2 grams per kg per day. We are kind of very eager to know what Sachin is going to share with us today regards to amount of protein. Dr. Naresh, do you want to comment anything on this?
No, this is fine. I think it's quite straightforward.
Yeah, okay. I'll stop sharing and Sachin can.
Thank you, ma'am. So coming to proteins. So as soon as if a preterm neonate is born, if you're not starting a baby on amino acid, so what happens? So this results in significant lot of body protein due to catabolism of proteins, and this is highest seen in most immature neonates. So for example, if you take a 26-weeker baby, so baby will be losing around 1.5 gram per kg per day of body protein. If you compare term baby, it will be off, like 0.7 gram per kg per day of body protein will be lost. And after only 3 days of no protein intake, it results in 10% of protein deficit. So it is very important to start a preterm neonate on amino acid on day 1. And there are fortunate evidences saying that early amino acid intake can compensate for high rates of protein loss, and it can preserve the body protein. And if you start a baby on 1.1 to 2.3 gram per kg per day of protein with a caloric intake of 30 to 50 calories per kg per day, it will result from negative. We can turn the negative nitrogen balance to positive nitrogen balance. So only proteins are enough. So we know that the proteins are the potential energy substrate mainly utilized for the tissue growth, and glucose and lipids mainly provide sufficient calories to avoid this protein metabolism. So the most important goal of the parenteral nutrition is to provide sufficient energy and nitrogen to prevent the catabolism of proteins and achieve a positive nitrogen balance. So here comes
so Sachin, just go back to the previous slide.
Yeah.
So we have got a second poll question for the audience. So just about your understanding on what is the ideal energy protein ratio you think for proper utilization of protein, 1 gram of protein. So sorry, are you seeing what is the ideal energy protein?
We can see the poll.
Okay, excellent. So I think we have got answers in terms of 20, 25, and 30. Ideally, yes, ideally we would all like to maintain a energy protein ratio of 30, but it is very hard in situations where the fluid is going to be very much limited. So at least if we could achieve 25, it is great. But majority of the times we might end up, in achieving somewhere between 20 to 25. But at least if you can understand the concept about energy protein ratio, and if we give adequate energy so that the protein is utilized only for muscle building, but not for energy. And again, there is a hitch here. The energy which you have to calculate should be only from non-protein calories. So it should be only from the carbohydrate and lipid you are giving. You should not include the energy which is derived from protein when you are calculating energy protein ratio. Yes, Dr. Sachin, over to you.
Yes, ma'am. Thank you, ma'am. So next we'll be seeing some concept about the energy protein ratio. So we'll be to ideal energy protein ratio that we have to maintain between 24 to 32. So what is this energy protein ratio? So if you are providing a baby a sufficient amount of amino acid, and if you are not providing non-protein energy source like glucose and lipids, so what happens? So whatever the energy, whatever the protein that you have provided, it will be utilized to generate energy itself. So it will be not utilized for the muscle mass. So we should be providing sufficient amount of non-protein energy, that is glucose and fats, along with protein for the usage of amino acids for the muscle mass. So there are studies saying that if you increasing the caloric intake increases the protein accretion. So they have studied that increasing caloric intake of around 50 to 80 kilocalories per kg per day significantly improves the protein accretion. So coming to studies which are showing that lower versus higher amino acid intake. So randomized control trials they have done. They're comparing 1 gram versus 3 gram per kg of amino acid in extreme preterms. So there they have seen that protein accretion was significantly greater in higher amino acid group. So what are the benefits of higher amino acid group? So it has resulted in increased weight, length, and head circumference. So next, coming to the concept of relationship between protein intake, ammonia, burn, and metabolic acidosis. So what is the relationship between these things? So usually there is no as such relationship between amino acid intake and ammonia concentration. And other important thing is the relationship between amino acid intake and burn. So here we have to see whether this is first week or the first 7 days or next after 7 days of life. So if it is first 7 days of life, burn and amino acid intake doesn't correlate. This is because burn usually correlates with the fluid status of the baby, and increased burn doesn't indicate the high protein. So it only after 7 days, higher intake of amino acid will correlate with increase in burn. So what is the relationship between metabolic ketosis and amino acid intake? So there are heterogeneous studies saying that amino acid intake will result in metabolic ketosis. This is one study where they have shown that increasing amino acid intake in extreme preterm, especially in 24 to 26 weeks of gestation, resulted in metabolic ketosis. This is mainly because these babies have bicarbonate loss and they have poor excretion of ammonium ion. So they are prone for metabolic ketosis. So there are Cochrane evidences saying there is no evidence as such with higher versus lower amino acid intake in other preterms. It's not in extreme preterm. So coming to pros and cons, as such, there are many advantages of starting higher amino acid intake as it results in greater protein accretion, prevents growth failure, it supports bone growth and promotes growth. So only thinking of metabolic ketosis, we should not inhibit in starting higher amino acid in preterms. So coming to amino acid solutions. So these amino acid solutions are mainly designed to mimic the plasma amino acid concentration of a healthy breastfed baby or fetal or neonatal cord blood amino acid concentration. So there is no as such convincing information the superiority of one amino acid solution over the another. So even though we have made substantiate advances in amino acid solutions, till now there is no amino acid solution that contains all the amino acids. So before going there, we'll discuss something about what are the types of amino acids. So there are mainly three types: essential amino acids, non-essential amino acids, and semi-essential amino acids. Essential amino acids are those which we can't synthesize in our body, and non-essential which we can synthesize in our body. But in semi-essential amino acids, which are 6, so these are some of the amino acids in some pathological conditions, body won't be able to synthesize these amino acids. So especially in preterms, it is they'll consider it as pathology, and these amino acids are not synthesized in preterms. So what are the importance of these amino acids? So mainly arginine, it is utilized for detoxification of ammonia, and cysteine, it acts as a precursor for taurine and glutathione synthesis. Glycine and tyrosine mainly acts as a neurotransmitter. Proline, it mainly utilized for precursor for collagen synthesis, and taurine is mainly utilized for fetal neurodevelopment. So what are the amino acids which are not present in amino acid solutions? Mainly glutamine, it is present abundantly in breast milk, and it is very essential for premature infants. But mainly because of the stability issues, it is not included in amino acid solution. There are some studies that have been conducted to see the efficacy of adding glutamine, but there is no such effect on NEC, feed intolerance, or growth in preterm babies. So next is tyrosine. It has a very limited solubility. That's why it is not included in amino acid solution. But trophamine is one of the amino acid solution which contains the derivative of tyrosine, that is N-acetyl tyrosine, but it has got poor viability. So third one is cysteine. It is not stable for a long period. That's why it is not included in some of the amino acid solutions. There are amino acid solutions that contain cysteine hydrochloride. So there are some benefits of adding the cysteine hydrochloride. So they have studied that it improves the nitrogen retention and improves the solubility of calcium and phosphorus, and it also improves the antioxidant glutathione. So these are some of the amino acid solutions. So what we use.
So regarding Sachin, just a note on glutamine.
Yes, sir.
So essentially, glutamine, I think in gastro, there are a lot of papers coming about the role of glutamine in gut regeneration. So for the cells to actively replicate, and in short bowel syndrome, oral glutamine is given to help the cells replicate. So in newborn, probably in NEC where there is a resection and short gut, when there is a problem happening, those scenarios, we give glutamine as an oral solution, and there are a lot of proven benefit that glutamine actually helps in cell regeneration, particularly the gut line.
Okay, sir. Sure, sir. Thank you, sir. Thank you, sir. So these are the composition of amino that we use in our unit. There are different concentration. 5% amino is there, 10% amino is there, 15% amino is there. So in our unit, we use a 10% amino, which contains 100 ml of solution. 100 ml is equal to 10 gram of protein. So what does the guidelines say? So I'll be talking mainly about Ispagan, NICE, and Aspen guidelines. So according to Aspen guidelines, we should start both the terms and preterms on 1.5 grams of protein, and we can reach a maximum of 2.5 to 3.5 in preterms. And according to NICE, can start around 1.5 to 2 and reach a maximum of 3 to 4. And according to Aspen, we can start around 1 to 3 and reach a maximum of 3 to 4 gram per kg per day. So coming to next topic, that is energy. The main goal of providing energy is to reach the rates of energy expenditure to preserve the body stores. So measures of energy expenditure in premature infants have shown that they consume around 30 to 70 kilocalories per kg per day. So this energy expenditure increases as the energy intake increases, as the age increases, and as the birth weight decreases. So what happens if you meet this energy? There are studies that have shown that meeting this energy expenditure, it improves the growth, neurodevelopment outcome will be good, and it decreases the adverse risk factors in these babies. So each component, like carbohydrate, will provide around 3.4 kilocalories per gram of 3.4 kilocalories per gram, and proteins will provide around 4 kilocalories per gram, and lipid is the highest, which gives around 9 to 10 kilocalories per gram. So to reach a neutral or slightly positive energy balance, we should be providing around 70 kilocalories per kg of energy. And to reach, to support the normal rates of growth, we should maintain a positive energy balance of 20 to 25 kilocalories per kg per day. So to cumulatively, around 90 to 110 kilocalories per kg per day energy we should be providing. So what does the guidelines say? According to Ispagan, on day 1, we should be supplementing around 45 to 55 kilocalories per kg per day and reach a maximum of 90 to 120 kilocalories per kg per day in preterms. Coming to next component of parenteral nutrition, carbohydrates. So mainly carbohydrate in parenteral nutrition is provided as dextrose. So soon after birth, we'll be starting the baby on dextrose solution to maintain the glucose homeostasis and preserve the endogenous carbohydrate stores. So once the baby is started on carbohydrate dextrose solutions, we should be seeing for hypoglycemia or hyperglycemia. And usually in all babies, the initial starting point will be around 4 to 7 JAR. So if you are managing a baby who is an extreme preterm, so we should be targeting a GR around 8 to 10 mg per kg per minute. This is mainly to match the endogenous glucose release. So once you have started the GR of 8 to 10, we should be reaching a maximum of 13 to 17 gram per kg per day from 2 to 7 days. And we should not give more than 18 gram per kg per day. That is because it can exceed the glucose oxidative capacity. So what are the other problems with dextrose in extreme preterms? The extreme low birth weight babies, they're usually intolerant to moderate GR also. So in these situations, temporary reduction to GR to 4 and we can help. And the usage of insulin in this situation is also controversial. So there are evidences saying that usage of insulin resulted in a weight gain, but there was no difference in head circumference or length. And it has increased. There was increase in fat mass, but there was no effect on lean body mass.
Sachin, just hold on for a minute.
Yes.
So we just have a poll question. So now that Sachin has brought this particular issue, namely insulin. So how many of you think that routine insulin in while using TPN would be beneficial, especially when you are increasing your glucose infusion rate? So how many of you think that routine insulin would be beneficial? I'm glad that many are actively participating in poll. So at least I'm ending the poll and sharing the reports. So it's quite impressive to know that many of you have answered the answered no. So I think now Sachin will tell us like why routine insulin is not beneficial. Sachin, over to you.
Sachin, could you also sort of tell what when you say that intolerant to moderate GR? So how do you define that term that somebody is actually intolerant to whatever glucose you are giving?
Yes, sir. So usually we'll be starting, if you're starting a GR around 68, then if you're coming down on, if you're seeing hyperglycemia, if you are planning to come down on GR with 4 also, there'll be.
That's what I'm asking. Hyperglycemia, what is the cutoff range and how do you define hyperglycemia and how do you handle the situation?
So hyperglycemia will be taking around more than CBG is more than 125, sir. So if you're in our unit, what we follow is if you're getting a GIR, the CBG is more than 200, then we should be two values. If the CBGs are more than 200, we should be checking urine sugars. If urine sugars are more than 2+, then and the GR you have come down to 4. Even with minimal GR, you are getting a sugars of more than 200 and urine sugar more than 2+. That's an indication to start insulin. So this is because the sugars are mainly because it can alter your osmolality. So the plasma osmolality we should be maintaining around 285 to 295. So because of hyperosmolality, they can induce IVH. So we should be starting those babies on insulin and bring down the sugars.
So exactly, I think that is the learning point here. I think whenever the sugars go high, I think there is no sort of specific limit to say like how high is high. I think it's with every institute has their own sort of cutoff values. But mainly, I think everybody will say that once you see sugar in the urine, I think that is a point where body is not tolerant. So that is the point of intolerance. And different hospital has their policies, and I would agree with what Sachin says. So essentially, when there is glucose intolerance, why we give insulin is just to push the insulin into the cells. So when there is a stress, your body can have a temporary insulin resistance. So the cells are not utilizing your sugar because the glucose is not actually entering into your cells. So this insulin helps to push this dextrose into the cells. So once it goes into the cells, then the body can utilize it. And that's the whole point of giving insulin. Please proceed, Sachin.
Yes, sir. Thank you so much, sir. So routine insulin is beneficial. Is it beneficial in babies? So there was a study that was conducted in 2008, and this study was published in NEJM also. So they have conducted routine supplementation of insulin along with the 20% dextrose, and they have seen that routine supplementation of insulin has resulted in no difference in sepsis, CLD growth, or NAC. But there was increase in mortality and hypoglycemic episodes in insulin group. So the answer is no. We should not supplement. Routine supplementation of insulin should not be practiced.
Just a minute, Sachin. I think just to reiterate the same point. I think most of them in the poll also have answered that routine insulin is no, and we are going to start only when the sugars are going up with 2+. And we need to be very careful because hypoglycemia is more harmful than hyperglycemia. I would like to stress upon this point also to all the trainees over here. So hypoglycemic brain damage is most of the time it results in cognitive, and we need to be monitoring sugars very carefully because sometimes they can be super sensitive to the insulin which you are administering. Yes, Sachin, please proceed.
Yeah, ma'am. Thank you, ma'am. So what does guidelines say? So comparing SPEN nice, SPEN recommends higher GR. It recommends around 68 GR in both terms and preterms, and reaching a maximum of 10 to 14. And if you take SPEN, it targets around 48 in preterms and reaching a maximum of 8 to 10 in preterms. So next component of parenteral nutrition is lipids. So lipids are mainly composed of triglycerides, phospholipids, and glycerol. So These intravenous lipid emulsions are nothing but suspensions of suspensions of oil in aqueous medium, which contain properties which are similar to natural chylomicrons. So fatty acids are nothing but monomers of lipid that consist hydrocarbon chains of varying lengths. So these can be present in various forms like cholesterol esters, which are circulating lipoproteins. Phospholipids are main component of cell membranes. Triglycerides, which are present in adipose tissue, blood, liver, and muscle. So these fatty acids can be classified according to the carbon chains into short chains, medium chain, long chain fatty acids, and very long chain fatty acids. So depending upon the number of double bonds, we can classify them as saturated fatty acids and unsaturated fatty acids, which can further classified into monounsaturated fatty acids and polyunsaturated fatty acids. In polyunsaturated fatty acid, mainly the omega-3 fatty acids and omega-6 fatty acids are very important. So in this flow diagram, we can see that omega-3 and omega-6 fatty acids. The alpha linoleic acid is a member of omega-3 fatty acids, and linoleic acid is a member of omega-6 fatty acids. So as we can see here, the downstream products, that is eicosapentaenoic acid and docosahexaenoic acid, are the components of omega-3 fatty acids, that is alpha linoleic acid, and arachidonic acid is a component of linoleic acid. So mainly the function of these omega-3 and omega-6 fatty acids, mainly they help in CNS development. They are the part of cell membrane, and they produce eicosanoids and prostanoids, which are mainly involved in vasoactivity, inflammation. So these
sorry, Sachin, just go back. Just one point here.
Yes,
generally, if we provide alpha linoleic or linoleic, that should be sufficient. Whereas in preterm babies, the conversion from alpha linoleic to the DHA or linoleic to arachidonic is very deficient. Even though arachidonic is inflammatory, it is needed for some of the main pathways. Inflammation, vasoactivity for that, like arachidonic is. So you have to have a balance between omega-3 and omega-6. So basically your DHA and arachidonic, something similar to your conditional amino acids. These are conditional semi-essential fatty acids, which becomes essential in your preterm. So both your DHA and arachidonic becomes sometimes semi-essential in preterm neonates. Over to you, Sachin.
Thank you, ma'am. So the intravenous lipid emulsions are mainly prepared by these 5 oils, that is soybean oil, safflower oil, coconut oil, olive oil, and fish oil. So mainly, what are the components that to be seen in intravenous lipid emulsion that differentiates all these lipid emulsions? So mainly, we should see the omega-6 and omega-3 fatty acid ratio. So omega-6 are mainly considered to be pro-inflammatory, and omega-3 is considered to be anti-inflammatory, and it is considered protective. And we should see the level of alpha tocopherol, which is an antioxidant, and we should see the levels of phytosterols. These are plant sterols which are associated with development of parenteral nutrition associated liver diseases. So coming to different oil emulsions based on lipid emulsions based on oil. So if you take a soybean oil, it is mainly rich in omega-6 and omega-6 fatty acid. It accounts for around 7:1 ratio, and it contains high levels of gamma tocopherol and low amounts of alpha tocopherol, and it is rich in phytosterol. So mainly all the bad things that are there that is present in soybean oil. So that's why we should not use soybean oil. So compared to soybean oil, soya flour is no different. It also contains the same thing. It is also associated with intestinal failure, associated liver disease. So coming to coconut oil, mainly it is anti-inflammatory. It doesn't contain as such pro-inflammatory properties, and it doesn't accumulate in liver. And these are devoid of essential fatty acids. That's why we can't use it as a sole source of fat. So next, olive oil, mainly it is contains small amount of omega-6 fatty acids, and it contains lower amount of phytosterols and abundant alpha tocopherol. And it contains monounsaturated fatty acid that is less pro-inflammatory, and it is resistant to oxidative stress. So it is somewhat good. So next is fish oil, which contains less pro-inflammatory, and it has got antioxidant alpha tocopherol, but even though it contains less amount of omega-3 and omega-6 fatty acid, it also has the downstream products, that is arachidonic acid and eicosapentaenoic acid and DHA. So these are the comparison of different amino acid, the lipid emulsions. So if you can see the intralipid, which is based on soybean oil, so it contains high levels of phytosterols, which are associated with liver diseases, and it doesn't contain the essential fatty acids, that is DHA and EPA, and there is no as such content at all. So if you take a fish oil, the omega-1 is a fish oil, so it contains less phytosterols, and it has a good amount of EPA and DHA. And if you contain, if you see the SMOF lipid, it is a combination of all the oils. That is, SMOF is nothing but soybean oil, medium chain triglycerides, olive oil, and mixed fish oil. So it contains all the oils. It's a mixture of all the oils, and it also has phytosterol. And DHA is comparably good if you take it, if you compare intralipid and SMOF lipid. So what are the factors that influence lipid clearance? So mainly the phospholipid concentration. So if you compare 10% versus 20% lipid emulsions, 10% has higher concentration of phospholipid, which results in accumulation of cholesterol and phospholipid, and it results in the formation of lipoprotein X like particles, which interfere with phospholipid clearance. So that's
just a minute, Sachin, like let me.
Yeah, ma'am.
So this is very simple. Like I think Sachin described about like various proteins and lipids. So we would like to know like what are the proteins and lipids you use in your unit? I think like majority of you have put as protein 10% and lipid 20%. So I think that is the recommended one where protein of 10%, 10 ml contains 1 gram, and a lipid of 20% where 10 ml contains the double the amount, and it is more concentrated. So your 5 ml of any intralipid solution will give you 1 gram of lipid. So when we are having fluid restriction, so this aspect is an important aspect to consider because you will be giving only restricted fluid, especially in the first few days of life. So now why we are using 20%, I think Sachin would give us an answer. Over to you, Sachin.
Yeah, ma'am. So mainly 10% has a higher concentration of phospholipid concentration, and it will result in the accumulation of cholesterol. So and thereby it results in formation of lipoprotein X-like particles, which interferes with lipid clearance. So that's why we should be using 20%, which contains lesser phospholipid concentration. So next thing that will be a factor that will be affecting is lipoprotein lipase activity. So mainly preterm neonates are handicapped with this reduced concentration of reduced activity of this enzyme, and heparin, as we add it in TPN, it also helps in clearance of lipid. So it mainly releases lipoprotein lipase from the endothelium and helps in clearance of the lipid. And there are studies saying that if you use intravenous lipids over 24 hours, the clearance of the lipid will be maximum. So these are some of the factors that influence lipid clearance. So coming to evidence, so there are studies that have been done and shown that early lipid administration is safe and well tolerated. Even if you start the lipid at around 2 gram per kg on day 1 itself, it increases the energy intake in very low birth weight babies. And what is the evidence for early versus late lipid? So there are no as such detrimental effects of early lipid supplementation, and there are no effects on death, bronchopulmonary dysplasia, and sepsis. But there is one thing is there is no as such beneficial effects on growth that could not be shown in these studies. So some of the practical consideration we should be seeing when we are using intravenous lipid emulsions. So we should be thinking about lipid peroxidation, because here there will be formation of free radicals and later which lead to tissue injury. So this is mainly it can be because of sunlight or phototherapy unit, which causes lipid peroxidation. So the major contributors for this lipid co-reduction are multivitamin preparations, and studies have also shown that if you are covering the lipid preparation, there are less chances of chronic lung diseases. So after preparation of the lipid, we should be covering with a sterile sheet so that it should not be exposed to light. So as we can see here, even the lines are covered with the aluminum foil, and the total preparation is covered with sterile sheet. So coming to preparation of parenteral nutrition, in our unit we use the Excel sheet where there are where we can, as we can see here. As we can see here in this Excel sheet, there are baby's details, the baby name, date of birth, and everything. The basic details of the baby should be entered here, and how much protein you want to start. Like protein gram per kg. If you want to start the baby on 3 gram per kg, we should enter 3, and 20% of the lipid you are using. So we should enter the numbers in 20%. And in the day 0, we won't be starting the baby on electrolytes, and calcium, how much you want to start, and MVI. So everything can be added here. So it will automatically give us how much amount of volume of these solutions that can be added. It will directly tell us. So you need not calculate anything. Okay. So what preparation of the TPN, we should be maintaining asepsis during the preparation. Dextrose and amino acid and electrolyte should be in one solution, and lipids and vitamins should be in one solution. And both these solutions should be connected by a Y connector. And we should be changing the tubes and bottles every 24 hours, and we should be avoid breakage of lines. And we should be using separate peripheral IV cannula for antibiotics and blood transfusion, because we won't be knowing the compatibility of these antibiotics and drugs with the TPN. So before, if you want to give, if the baby is sick, if you want to give antibiotics through the same line where TPN is going, we should first see the compatibility. In UpToDate, there is a Lexicomp comparable, so we can enter the drug there, so it will show whether the drug is compatible or not. So we can use after that, if drug is compatible, we can use that drug in the same line. So this is the diagrammatic representation. So where we are using amino acid, dextrose, and electrolytes in a separate bottle, and the lipid emulsion in a separate bottle, and it is connected in a white connector. So this is how we prepare our solutions, total parenteral solutions. So as we can see, the senior nurse will be involved in preparation of the total parenteral nutrition, and postgraduate is involved, and it will be all the drug mixing will be under this laminar flow. So this is a short video. So as we can see, everything is kept in the tray, and it will be taken and it will be checked by the senior nurse. So once they are ready, so they'll be keeping it inside and start mixing it under the laminar flow. So in this video, you can see the mixing. So after checking everything, the insert sister will give the solution. So the postgraduate or trainee will start preparing the solution. So all these things should be under aseptic precautions, and it should be under laminar. So what does guidelines say about intravenous lipid emulsions? So according to ESPGHAN guidelines, lipid should not be started no more than day 2 of life, and we can give maximum of 4. And according to NICE, we can start 1 to 2 grams, and we can reach up 3 to 4 grams. And ESPGHAN, ASPEN guidelines, so it starts low with a lower lipids, and we can give maximum of 2.5 to 3 grams per kg per day. So what is the role of carnitine? So carnitine is an amino acid. So what is its role in fatty acids? So it mainly facilitates the transport of long chain fatty acids. It plays a very important role in their oxidation. And usually preterm infants has low carnitine levels. So there are studies that have done that adding carnitine, but there was no as such effect on ketogenesis, lipid utilization, or weight gain. So currently there is no recommendation of adding carnitine in parenteral nutrition. So, some information regarding essential fatty acid deficiency. So as we know, essential fatty acids, alpha linoleic acid, linoleic acid, if they are deficient, it may result in growth retardation and eczematous dermatitis and alopecia. To avoid this, we should be giving at least 0.5 to 1 gram per kg per day of IV lipid. So in this picture, we can see the eczematous dermatitis in this baby. So coming to next component of parenteral nutrition, that is electrolytes, minerals, trace elements, and vitamins.
And just hold on.
Yes.
So just very simple, we want to know like how your unit is. So we want to know whether you add calcium in PPN. So you can answer like S only calcium, S calcium and phosphorus. No, we do not start calcium and phosphorus. And again, trace element, whether you would like to add from day 1 or day 3. So I'm ending the poll. I think we have gotten like almost equal answer for only calcium and calcium and phosphorus. Few of you are not adding calcium or phosphorus. So what we want to stress upon is if at all you are adding calcium, it should be only along with the phosphorus. Adding only calcium would not help the baby in any ways. So again, do you add the trace elements? I think it's almost equal answer we have got for yes from day 1 and yes from day 3. So in our unit, we practice adding trace elements from day 3. Let us see whether Sachin would be able to kind of take us through this. Over to you, Sachin.
Yes, ma'am. Thank you, ma'am.
Actually, sorry, I have not shared the results. I just checked. Yeah, these are the results which we got for various groups. Yeah, thank you. Over to you, Sachin.
Yes, ma'am. Thank you, ma'am.
Is it?
So next component of parenteral nutrition is electrolytes, minerals, and trace elements and vitamins. So mainly first, before going there, we should first there are some physiological concepts that we need to understand. So there are 3 phases. The phase 1 will be transition phase after birth that will last around 5 to 6 days. First 5 to 6 days. Initially, all the babies will be on relative. They'll be relative oliguric, and then they'll be going in for diuretic phase. So there'll be isotonic or hypertonic contraction of this the fluid status. And once the maximum weight loss occurs up to 10%, we can start adding sodium, potassium, and chloride. So it can range from 0 to 3 to 0 to 2 or 0 to 5 millimole per kg respectively. So these and the subsequent days, the addition of these electrolytes can be dependent on the baby's weight and the sodium values and potassium values. So next phase 2, there is a stabilization phase. So after this initial transition phase, which lasts from 5 to 15 days, after this, there will be extracellular fluid contraction will be there where all the electrolytes will be lost. We should replete this body electrolyte loss. So we should be supplementing sodium and electrolytes after in this phase. So next in phase 3, that is considered as a growing phase, that is after 2 weeks. So we should be aiming for stable growth with continuous weight gain, and we should be targeting positive net balance for water and electrolytes. So here we should be providing more sodium and potassium. So we should be giving around 4 to 6 millimoles per kg per day of sodium and potassium of 2 to 3 millimoles per kg per day. And if you take extreme preterms, we can go up to around 6 to 8 milliequivalents per kg per day, or even higher. So sometimes we can go up to 10 to 12 milliequivalents per kg per day also, depending upon the sodium loss and the baby's weight gain and the clinical evidence of edema is there or not. So these are the guidelines so for supplementation of sodium, potassium, and chloride. So next, some talk on calcium and phosphorus. Mainly adding the calcium and phosphorus remains a significant challenge because of the limited solubility. And usually in our unit also we use a calcium gluconate, but alternatively we can use a calcium chloride. So phosphorus can be given as potassium.
Sachin, just hold on.
Yes, sir.
Go to the previous slide on the sodium.
Yes, sir.
So how do you choose whether it's going to be 2 milliequivalents, 3 milliequivalents, 4 milliequivalents?
Sir, so initially, if you are seeing any baby, so two things we should be seeing: lab parameters and clinical condition of the baby. So clinically,
Okay.
so lab parameters, if there is evidence of hyponatremia, and clinically baby is not gaining weight,
Okay.
or baby is edematous. So this edema, when baby is edematous, and if you are having a hyponatremia in the lab, so we should be attributing to dilutional hyponatremia. So there you can't supplement, add 3% NaCl. So whenever there is no weight gain and there is hyponatremia, then we should be thinking that this hyponatremia is because of urinary loss of sodium. So there you should be supplementing 3% NaCl.
So essentially, I think all children, babies on long-term TPN, we should measure the urinary sodium.
Okay, sir.
Ideally, the urinary sodium should be more than 20, which
Okay,
means
sir.
that body has excess of sodium that is excreting it out through the
Okay, sir.
kidneys. If it is less than 20 millimoles, which means that the body is suffering from sodium deficit. The serum sodium and other parameters will not sort of tell you what exactly the whole body sodium is. So,
Okay,
so all of you who are listening this, make sure in clinical practice, whenever you are putting up TPN on babies, always check every week urinary sodium. Make sure that the urinary sodium is more than 20. If it's less than 20, which means that even whatever the serum sodium can be anything to anything. So that's quite variable based on your body fluid and all sort of things. The amount of sodium you put can sort of go up to as high as 6 millimoles.
Sir, this 20 cutoff is for universal preterms, sir, or is there any cutoff for extreme preterms or moderate preterms?
I don't think there is sort of much values on this cutoff, because I think there is only one value which I came across, and practically I think in UK and all, I think probably they are slightly bigger children who are like 1 month old, 2 month old with short bowel, who are on long-term TPN. Whenever they are not growing, essentially we check the urinary sodium to titrate the serum, how much of sodium we need to put in the TPN.
Okay, sir.
Actually, generally, extremely low birth weight babies would need more sodium because more sodium is lost because of immaturity. And again, it is in context to the fractional excretion of sodium as well. So generally, even if we take in context to the creatinine, and if you calculate left PINA, fractional excretion of sodium, it would be high with extremely low birth weight babies. And in fact, Dr. Anvesh, one of our DM candidates, he did his thesis on sodium and he found better growth with more supplementation, but it was oral supplementation during the growing phase, not in the TPN. Because most of the time for preterm TPN, though we call it as TPN colloquially, it is not TPN as such. It is not total parental nutrition. It is only partial parental nutrition along with enteral.
And I agree that I think most
Yeah.
of the time we give it for like few days and then start on EBM and all those things.
Yeah.
I think long run, I think children who are on long term, I think measuring urine sodium will be helpful
Yeah,
to
sure.
supplement more sodium.
Yeah. Yeah, very true. Very true. Yeah. Yes,
Yeah, ma'am.
continue.
Yeah, ma'am. Thank you. So next we'll talk something about calcium and phosphorus. The adding calcium and phosphorus again remains a challenge because of their solubility. Mainly in our unit we use calcium gluconate. Alternatively, we can use calcium chloride also. And phosphorus we can either use it as a potassium phosphorus or sodium phosphorus. In our unit we use it as potassium phosphorus. So what are the factors that increase the calcium phosphorus solubility in parenteral nutrition? The solution should be acidic in nature, and there should be high concentration of dextrose or amino acids. And cysteine hydrochloride, as I mentioned before, even it increases the solubility, and we should be maintaining a cooler temperature. And there should be appropriate calcium and phosphorus concentration that should be present. So our unit preparation for there are different preparations for central line and peripheral line for both calcium and phosphorus. If it is a central line, we'll be giving 6 ml per 100 ml calcium, and if it is a peripheral line, we should be adding 3.6 ml per 100 ml. And for phosphorus, we will be adding 0.35 ml per 100 ml, and peripheral line will be adding 0.2 ml per 100 ml. So that will be the concentration that is mentioned below, like 19 mg, 34 mg, and calcium around 56.5 mg, and peripheral line 34 mg. So these are the recommendations for calcium phosphorus according to Ispagan and Aspen. So coming to trace elements, so there are 8 trace elements that should be supplemented in parenteral nutrition, according to such as chromium, copper, iodine, iron, manganese, molybdenum, selenium, and zinc. So mainly they act as a cofactors and cofactors for many enzymes. So I'll be mainly focusing on iron. So mainly iron is not added in parenteral nutrition for a short-term parenteral nutrition. For it is better preferred to add iron as a enteral route. And if you are giving a long-term TPN as such in cases of short bowel syndrome, a daily dose is added to the solution, or it can be given intermittently as a separate infusion. So it should be monitored by doing an hemoglobin or ferritin in cases of long-term TPN babies. So zinc is one of the trace element we should be starting on day 1 itself. So zinc deficiency can also present as skin rash or even growth retardation. So these are some of the guidelines on trace elements. So the requirements for preterms and babies between the 3 months to 12 months of age. So coming to last component, that is vitamins. So mainly they function as coenzymes and cofactors that are required for metabolism of macronutrient, that is carbohydrates, proteins, and lipids. But the thing is that still there are not yet well-established requirements that are put forth for vitamins. And preterms, they are because of their decreased stores of fat-soluble vitamins, because of their shortened in utero time, they are in need of vitamin supplementation. So what are the current formulations that we are facing problems? So there are no as such products that will meet the full needs of preterms. We are using the pediatric vitamin formulations, and there are only 2 preparations that are available in market now. So first one is for 40% MVI pediatric vial, and the other one is Infovite pediatric. So we'll be So what are the problems with the current vitamin formulations? They do not meet the needs of premature infant for fat-soluble vitamins. And some of the vitamins like vitamins and B12, B2 are provided in excess. So this is the multivitamin vial that we are using in our unit. So these are the guidelines for vitamin usage in parenteral nutrition. So coming to some light on osmolarity. So it is the measure of osmotically active particles in solution per solute per liter of solution. Mainly, it is influenced by the concentration of dextrose and amino acid concentration. So it is critical to assess the osmolality when we are giving, whether you are giving central TPN or peripheral TPN, because it can cause thrombophlebitis. So evidence has shown that the osmolality for peripheral TPN can be ranged from 400, central TPN can be ranged from 400 to 1700. And there is a limited evidence for rate of infusion that we should be keeping. And there are differing definitions for tolerable rate of thrombophlebitis that can be there. So according to guidelines from ESPAG and ESPAN, so they recommend around 900 millimoles per liter for a peripheral TPN, and ESPAN also recommend the same. So coming to monitoring of a baby on parenteral nutrition, so we should be able to monitor using intrauterine growth charts. So we should be targeting around 15 to 20 gram per kg per day of weight gain until 36 weeks. And after 36 weeks, we should be targeting around 20 to 40 gram per kg per day until 2 months of age. So the biochemical monitoring we should be done using glucose, serum electrolytes. For fat tolerance, usually in a long-term TPN, we can do triglyceride levels and phosphorus levels, mainly to avoid neonatal refeeding syndrome, which I will be discussing further slides. So liver function test, if you are giving a long-term TPN, we usually in our unit do checklist for babies who are more than 7 days on TPN. We'll be doing all these investigations. So mainly the trace element and the vitamin status will be done only during a long-term TPN. Otherwise, we won't be doing routinely in other babies. So the clinical monitoring, weight daily, we should be checking. Length and its circumference should be checked weekly. Serum glucose per shift initially, and later we can change it 12th hourly. And the serum electrolytes are initially in the more frequent way, and then we can change once the baby is stable. We can change it weekly. And alkaline phosphatase mainly to see the metabolic bone disease part. After 21 days, you can start doing alkaline phosphatase level. So clinically, so there are signs that we should be looking for, there are the trace element deficiency, vitamin deficiency. They can present with cutaneous abnormalities of skin, hairs, and nails. So mainly the skin zinc deficiency, as I told you before. So they can present with the skin rash, as you can see the dry erythematous skin in this baby. So coming to complications that are associated with parenteral nutrition, mainly we should be watching out for cholestatic jaundice, that is parenteral associated liver disease. So mainly this is because of the hepatic dysfunction. Histologically, they can present with cholestasis in intracanalicular and intracellular, and intracellular. And it can be reversible if you are stopping the TPN, and it can become irreversible if you are using TPN for a prolonged usage, like cases of short bowel syndrome. So etiology of this cholestasis is multifactorial, and the greatest risk is seen in hypoxic babies and hemodynamic instability babies, and in which sepsis is associated. Also, they are at high risk for liver disease. So there are studies that have been shown that if you are using a fish oil based product, then the incidence of these liver disease is less, as I told, because these contain omega-3 fatty acids rather than omega-6 fatty acids. And there are RCTs that have been conducted comparing fish oil versus soybean oil in short bowel syndrome, and they have shown that lower rates of mortality and higher rate of reversal of cholestasis was seen in fish oil based intravenous lipid emulsion. And they have used phenobarbital and ursodeoxycholic acid, but none of them have proved to be benefit in prevention of liver disease. So next, we should be talking about neonatal refeeding syndrome, which is also called as placental incompletely restored feeding syndrome. So as we all know, the extreme preterm babies and growth restricted babies, they'll be in suboptimal intrauterine environment, and soon after birth, we'll be starting them with enteral or IV parenteral nutrition. So once you start, there will be cluster of electrolyte disturbances like hypophosphatemia, hypercalcemia, hypokalemia, and hypomagnesemia, and they can also have hyperglycemia and thiamine deficiency. So because of this incidence of this refeeding syndrome, ESPGHAN 2018 recommends starting sodium phosphate and potassium supplementation from birth. But this is a level 1 evidence. So still further investigations are needed. For that, we are not starting any babies on these supplements for now. So this is the flowchart. We can understand the pathophysiology of neonatal refeeding syndrome. So as the baby is malnourished inside, so once it postnatally we are starting the baby on glucose, fat, and proteins. So there will be production of insulin, which results in movement of phosphate and potassium inside the cells, and it results in this biochemical picture, that is hypophosphatemia, hypokalemia, hypomagnesemia, hypercalcemia, hyperglycemia, and hypernatremia. So because of severe hypophosphatemia, they can have muscle weakness, and they'll be in need of mechanical ventilation for a prolonged time, and which further results in chronic lung disease. And this also can cause intraventricular hemorrhage. So it can further lead to impaired neurodevelopment in future. So it also results in as the ions are moving inside the water, also it moves inside and results in osmosis. So ATP depletion will be there, which results in phagocyte dysfunction, which further results in sepsis. So coming to other complications which are associated with parenteral nutrition, mainly catheter related. The most common organisms that are isolated with catheter are Staphylococcus epidermidis and Staphylococcus aureus, and fungal infections like Candida albicans and Malassezia furfur are some of the fungal infections that are associated with catheter. For prevention of these catheter associated infection, we should be meticulously assessing every day whether there is a need for line. So if you are able to establish central feed, better will transfer from parenteral to enteral as soon as possible, and assess daily whether there is a need for central lines. If there is no need, we'll take out those lines. So they have also studied prophylactic low-dose vancomycin in prevention of catheter-associated infections, but there are diminishing incidence of sepsis. But the more concerning things are the origin of antibiotic resistance in organisms. So that's why it is not recommended to use low-dose vancomycin in such cases. So other complications like excess, if you give excess carbohydrate, it may result in hyperglycemia, and it may result in worse neurological outcomes, and that may affect the respiratory outcome requirements also, because it mainly affects the respiratory quotient. So as the respiratory quotient, if you increase the CO2 buildup will be more, so the weaning from ventilator will be difficult. So if you are giving excess fat, it may result in fatter, shorter, and less muscular infants, and they can have long-term neurological deficit. And if you are giving excess protein which is not required, they can result in oxidation of these amino acids. So take-home message is, we should be starting early and aggressive nutrition. We should be taking into account the energy protein ratio concept and maintaining between 24 to 32. And early use of lipids are resultant in good growth and development. So we should be starting lipids on day 1 itself. So we should monitor the growth of these babies on total parenteral nutrition, both clinically, laboratorically, if the baby is requiring long-term TPN. So we should be monitoring the complications like cholestasis and metabolic bone disease. And as soon as possible, it is best to shift from parenteral to enteral if the situation persists.
Thank you, Dr. Sachin, for an elaborate presentation. So we'll just go to the questions, or Dr. Naresh, you want to give your opinion, then we go to questions, whatever you say. Dr. Naresh? Okay, meanwhile, we'll just go to questions. I think we have here a few questions. I'm glad that at least 50 participants have stayed back till the end. So Sachin, in extreme preterm, how many days or months we can continue amino if not gaining weight with full feeds and HMF? Do you advise MCT oil?
No, there is, as such, there is no cutoff for how many days that we have to use amino. It's better to, if baby is tolerating enterally, we should be shifting to enteral feeding as soon as possible. And if you are giving a full feed with HMF, we can increase the fortification. We can make it, if you are giving one sachet of lactose HMF in 25 ml, we can make it 3 sachets in 50 ml. And like that also we can increase the protein requirement and caloric requirement. And one more way of increasing the protein or kilocalories is increasing the feed itself. The volume, we can increase the volume. So we can go up to 22, 25. Sometimes we have gone up to 50 also. So even then, if we have done all these measures with protein with 3 calorie dense and reaching the maximum volume, even then baby is not gaining weight, yes, we'll add MCT oil. For now, I think I've used only for only one baby. Apart from that, we have not used MCT oil. So the problem with MCT oil is it only increases the fat mass. It doesn't increase your lean body mass. So baby will become fat, but the muscle mass will not increase. So it will look chubby, but it is not a good sign.
Yeah, I think well answered. I think to take that point very correct. Only enteral feeds would make the baby gain weight. That time we will not be putting on any amino weight. For a feeding and growing baby, is there a role for TPN or amino weight? The answer would be no. I'm not really understanding the next question. PCR required in short bowel syndrome. So can the person itself unmute or like clarify the question a bit more in the chat box? Or like you want to unmute and ask? What do you mean by PCR? I know only one PCR, polymerase
I
chain
was also sort
reaction.
of looking at that question and saying, what is
Okay,
PCR?
the only one thing which I could think from a genetic perspective
Protein
as well as
calorie
from an
ratio.
infection. Okay, protein calorie ratio. Okay. Fine. Required in short bowel syndrome. I think it should be uniformly applicable. So we call it as EP ratio, energy protein ratio. So protein calorie ratio. Okay, a new terminology as such. I think that is important in any perspective. So if you are not providing adequate energy, that protein is not going to get utilized for muscle building. So definitely an answer is yes. So the other question is comparison of different amino acid solution on outcome on metabolic acidosis and growth. Sachin, do you want to take this question? Different amino acid solution on outcome on metabolic acidosis and growth.
No, ma'am, no idea, ma'am.
There is nothing like that. So all the amino acids, as long as it is providing all the essential and semi-essential amino acids, that should be sufficient. Metabolic acidosis, one Cochrane review which came said that amino acid solution did not increase the incidence of metabolic acidosis. But however, comparison with different amino acid solutions were never done.
Yes.
So amino acid should be in an optimal concentration, should not be more or should not be less. I think Dr. Naresh, like if you want to answer this, help us out in this, answering this question.
No, I don't think there is. Yeah,
brand name
sorry, what is the question?
Brand name of glutamine orally and the recommended daily allowance of glutamine, because you were bringing this up for doing in short bowel syndrome. So I think they want to ask.
I can't remember the brand name, but it's widely available, and even sort of like hepatic rescue. I think a lot of formulation available on the adult market for mainly as like a hepatic rescue or a supplement with for hepatic. Usually we give 100 milligram per kg per day. For enteral nutrition for children who has issues with it's an oral supplement, not an IV. It has to be given orally. So they think it acts locally.
Okay, yeah, thank you. I think like from my perspective, I think any amino acid powder, if you are saying Pristine can prepare and give us because like we are using many isolated amino acid powders for some of the metabolic disorders as such. So arginine is widely available as brand name. Glutamine I do not know, but any amino acid powder as such, citrulline or any amino acid powder as such is available from Pristine. If you order, they can procure and give it for you. What is the protocol about insulin if RBS is more than 200 to 300, especially seen in post-op case? Sachin?
I don't think any difference or different in protocol is there for those babies. If you think babies in under stress, you wait for some time until baby is not in polyuric stage, and you measure keep the GR around 4 and see for the urine sugars. If more than 2 plus, and if you have given enough time, it's better to consider insulin for those babies also.
I think basically they are asking about sliding scale. I think your unit should have a protocol for sliding scale depending on what is the level of random blood sugar or like CBG. You should have a sliding scale of insulin. Most important aspect is binding of insulin with the plastic tubes. So whenever you are preparing insulin, you need to make sure that you prepare double the quantity of insulin, whatever you are preparing, connect the extension and flush it so that all the plastic tubings get saturated with the insulin. And sometimes if time is available, we do keep the solution along with the tube for 20 minutes so that the plastic tubes are saturated, then connect to the baby. So that aspect also one should take care on when you are starting on insulin. Any association between increase in rate of sepsis and lipid infusion? Interesting question. Sachin, you want to answer this?
There are studies that have been done, but there are no evidence saying that lipid use will increase the incidence of sepsis. So there is no as such the evidence saying that we should stop using lipids.
Yeah, I think there are a lot of myths and facts as far as lipid is concerned. So see, it causes, in thrombocytopenia, you should not use hyperbilirubinemia. You should not use in sepsis. So there are many myths rather than facts as such. Like the free fatty acids will kind of displace bilirubin. So all these things are the things which should be considered. But having said that, any extremely low birth weight babies have to undergo that phase of phototherapy, phase of some probable sepsis, etc. So if we are withholding lipid for each and everything, then we won't be giving sufficient calorie, and your EP ratio will not be met. So I think there are a lot of myths about lipid infusion rather than facts. Dr. Naresh, do you want to comment on that as well?
Yeah, I would agree. I think people give a knee-jerk reaction whenever there is a sepsis. Immediately, they want to stop lipids and all sort of things. So far, there is no known evidence to do those things. Essentially, obviously, when child is 2-6, having 3 inotropes running, but I think that would be a situation where we wouldn't be concentrating on TPN at that point. But there is no contraindication whenever there's a child having sepsis or whatever, we continue the lipids, and you should do that because they need more calories at the time.
Yeah, sure. Thank you so much. I think the next one is just a comment. Next one is hyponatremia associated with NNEC. Shouldn't we supplement? I think it is not under the purview of TPN as such. It is a discussion per se, but one has to remember that there is a third spacing in any NNEC. It is not that the total body sodium is going to be depleted. So many times you might have to judge whether you have a third spacing, whether there is a dilutional effect on sodium, then consider supplementation of sodium in NNEC. Next question is Sachin. This is a proper TPN question. Does calcium gluconate and potassium phosphate precipitate if added in same solution?
No, don't precipitate now.
Okay. So is there any precaution you would take while adding?
So we should be adding these solutions at the end of preparation of all the solution.
Exactly. So that is the clue. So you have to add all these things, and then at the end you add. And I really do not actually, I kind of miss this Y connector. You do not have to really connect by Y. You can have lipid infusion separately. Generally, the osmolality of lipid is very low, so you can connect even in a peripheral line, no harm. Because lipid is sometimes dense, it might sometimes lipid instead of going in, it might come throw the Y piece into the other solution. So as far as possible, run 24-hour lipid separately as an infusion, and then other TPNs you can put together. And while adding TPN, add calcium and phosphorus at the end. Generally, no calcium alone without phosphorus supplementation. How you add trace elements?
So
So
there is no, yes, ma'am. Yes.
yes, please, yeah, go on.
There is a separate IV preparation, Otsky, by the brand name Otsky, OTSKY. By that we can add trace elements.
Yeah, it is just like how you add sodium, how you add potassium, like that you add in the TPN solution. That's all. How do you calculate osmolality? Sachin, do you want to go to the Excel sheet?
Yes, ma'am. 1 minute.
So you just scroll down. Before that, I will go to the. Can the Excel sheet be shared with us? We are happy to share the Excel. So we will make sure that it is shared in the group. Comment on lipid use and hypo email and increased pH with lipid infusion in 24-2. So can someone elaborate on this question? So comment on lipid use and hypo email. I think there is some typo error there. I could recognize that there is some typo error. Dr. Aritra Ray, you can kind of clarify on that question as such. Before that, I'll just answer quickly. This
Hello, ma'am.
hyperglycemia associated with poor neurological outcome. Both hypo as well as hyperglycemia is associated with poor neurological outcome. What we are trying to say is hypo is worse compared to hyper, but both are bad. Like, both you should not be having. Yes, Dr. Ray.
Yeah, ma'am, actually, I'm asking, is there any studies suggesting that infusion of lipids increases the oxygen requirement of the babies, or there is increased incidence of pH in those babies of extreme preterm?
Okay, so in fact, lipid infusion, you have less respiratory quotient, so it is unlikely to, increase your respiratory. It will not. In fact, carbohydrate has a higher respiratory quotient, so you have more CO2 produced because of carbs than lipids. PPHN, like there are few animal studies, but not in human beings. There is no proven PPHN association in extremely preterm babies. So extreme preterm babies PPHN is a different kind of PPHN because it is due to embryonic defect rather than PPHN person. So this osmolality, if you see here, actually we have the calculator. So depending on the grams of protein lipids, the osmolality is being calculated. So Sachin, you can, okay, this is not a live thing, no? Otherwise you can change and show so that people can see. So all the fluids will have osmolality. Say for example, lipids have this much osmolality, carbs have this much. Each gram of dextrose will have this much of osmolality. So in our Excel, how it does this, it automatically calculates depending on the whatever solution you are feeding, it automatically calculates the osmolality and gives us. So whenever it is more than 900, it will alert that it should be given only in the central line. If you are giving in peripheral line, it will alert as a red alert. So we can share with you this, but there are some other calculators also. I was seeing in the net, there are some other calculators also to calculate TPN osmolality. I think it has been a very long session. Dr. Naresh, any concluding remarks from your side?
My concluding remarks are like enteral nutrition is always best. So TPN is only a short-term fix. So always try to feed these babies as early or as soon as possible. So that's all my take on. And I think I really enjoyed this session. It's quite in detail and quite elaborate, and I'm quite amazed to see quite a lot of people join. Thanks, Suma.
Thank you so much for all of them. Thank you, Sachin, for such a wonderful presentation. I thank
Thank you,
each
sir.
and
Thank
every one of you for actively participating and staying with the end. Thank you.